Hi, in this lecture, we're going to look at the adrenal glands. Now, you can call these glands the adrenal gland or the suprarenal gland. It's completely up to you. But what you'll notice is that each of these is on top of or superior to each kidney. And so that's why they're sometimes called suprarenal glands. Now, these glands are critical for life, just like most other endocrine organs. If we were to look inside of them, they have what's called an adrenal cortex and an adrenal medulla. They make many hormones, over 24 different hormones. We're only going to really be learning 2 hormones, but they're mainly synthesized from cholesterol. So sometimes when you see a slide of the adrenal gland, they look yellow because cholesterol is a yellow color. But we have this outer area, which is called the adrenal cortex, and then we have the inside of it, which is called the adrenal medulla. Now, the adrenal cortex, remember, makes steroid hormones. Steroid hormones are made in 2 places in the body. They're made in the adrenal cortex, and they're also made in the gonads, the ovaries and the testes. The adrenal medulla makes protein hormones, and you actually already learned of these. They're norepinephrine and epinephrine, which we talked about with the sympathetic nervous system. So this is another picture of the adrenal gland. You can see number 1 is showing you the adrenal medulla, and number 2 is showing you the adrenal cortex. And as we mentioned, these hormones come from cholesterol. They do need protein transporters to carry them through your body because they're lipids, and plasma is mostly water. And so when we're looking at the cortex, a lot of times you might see the word corticosteroid, and corticosteroid means the hormone comes from the adrenal cortex. Because if you hear steroids, right, or steroid hormones, there's anabolic steroids, which we're looking at mainly affecting the testes, right, like forms of testosterone. And then there's corticosteroids, which means they come from the adrenal cortex. Okay. Now, if you look at the cortex here, you can see some shading differences. You can actually see 3 little colors here because there's 3 zones in the cortex, and so they're called zones. So here's the medulla. The one closest to the medulla is the zona reticularis. The one in the middle is the zona fasciculata, and the outermost one is called the zona glomerulosa. So the zona fasciculata is the one in the middle. The reticularis is the deepest one, that's over by the medulla, and the glomerulosa is the outermost one. And they make different types of hormones. So again, this one, they flipped the view. Here's the adrenal medulla, so zona reticularis, fasciculata, glomerulosa. Now, the glomerulosa is the outermost zone, and that makes what are called mineral corticoids. So these affect minerals. What they're going to affect is sodium and potassium. The middle zone, fasciculata, makes glucocorticoids. So these are steroid hormones that affect blood glucose levels. And the reticularis makes both, but it also makes gonatocorticoids. So we'll look at each of these next. Okay, so let's look at the mineral corticoids first. So the first one we're studying is a mineral corticoid. It's called aldosterone, and its main action affects sodium and potassium levels. So it targets the kidney. The part of the kidney is called the nephron. That's the basic functional unit of the nephron. The nephron basically sorts out your blood and determines what leaves your blood and goes into your urine to be excreted from your body and what is coming back into your blood. And so what it does is it increases sodium reabsorption. So what that means is that sodium is going to go back into the blood so that there's less sodium in your urine. Okay, so it increases sodium reabsorption, or we could say it decreases sodium secretion. So secretion, it's going in your urine to leave your body. Reabsorption, it's coming back into your blood. Now, water likes to follow sodium. So think of water and sodium as being BFFs. So water tends to want to follow sodium back. Let me draw this a little better and make it correct. And so it also tends to increase water reabsorption, or think about it as bringing water back into your blood. So what this would do is it would increase your blood volume. So you'd have more water in your blood, so your blood volume would go up and your blood pressure would go up. Now, at the exact same time that it does that, it gets rid of potassium. They always go in opposite directions. So when sodium comes back, notice potassium leaves, and potassium goes into your urine. Now, it also can help pump hydrogen out as well. A lot of times when sodium comes back, typically a potassium or a hydrogen can go. We're going to talk a lot more of this when we do A&P2. I'm not too concerned about that for this lecture. I'd like you to to know that for every sodium that comes back in the blood, a potassium has to leave. It also increases sodium reabsorption in your sweat glands. So it really tries to maintain your sodium levels. So because that's its main job, right? If you think about what a hormone does, you can figure out what triggers its release. Well, if its job is to bring sodium back into your blood, if your sodium level's too low, that will trigger the release of aldosterone. Its job is also to get rid of potassium, right? So you urinate more. So if your potassium levels are too high, that would trigger the release of aldosterone. Now, it is controlled by ACTH. So, by the way, this is a humoral stimulus, right? We're looking at our electrolyte levels, sodium, potassium. There's a hormonal stimulus. ACTH is a tropic hormone. And so it is in the pathway of CRH and ACTH. But typically, when CRH increases ACTH, it releases some aldosterone, but it actually mainly affects the other hormone from the adrenal cortex called cortisol, which we'll get at soon. But we also know that stress raises CRH release, and so that can also trigger the release of aldosterone and cortisol. But again, stronger link to cortisol, which is coming up next. There's another mechanism. There's an enzyme, you call it renin or renin, and there's this really big protein called angiotensinogen. So this is a really important mechanism that you need to understand. This directly comes back in AAP2. So the liver makes this protein called angiotensinogen. The kidney releases an enzyme called renin. So when renin is released, it's an enzyme, so it catalyzes a reaction. It converts angiotensinogen into angiotensin 1. So this is the reaction catalyzed by renin. Now, angiotensin 1 travels in your blood, and when it gets to your lungs, there's another reaction that happens. Angio 1 gets converted into angio 2. And the enzyme that does that is called angiotensin converting enzyme, or ACE, which you've probably heard of ACE before, ACE inhibitors. So that's the enzyme that gets angiotensin 2. When we get angiotensin 2, it does two really important things. Number one, it vasoconstricts your blood vessels. So that's going to raise your blood pressure. Number two, it goes to the adrenal cortex and releases aldosterone. And renin is one of the main mechanisms that is releasing aldosterone, because then remember, you're going to increase sodium reabsorption, water will follow it, you're going to raise your blood volume, you're going to raise your blood pressure. So anytime your blood pressure falls, this is going to kick in so you can try to bring it back up again. It's a very important reaction. Now, if we're looking at aldosterone, we can have hypersecretion of aldosterone is the first one. So aldosteronism could happen from tumors. So you could have cancer in the adrenal cortex, and a lot of times when that happens, you'll start producing a lot of aldosterone. And if you're making a lot of aldosterone, then you're going to be holding on to a lot of sodium. So you're going to have a lot of edema because water will follow it, and you're going to have too low. You're going to lose a lot of potassium ions, and that can really affect your heart and your skeletal muscles as well. So there's a little question here, a little clinical application. It says a patient had high blood pressure. He has hypernatremia, hypokalemia, high blood pH, low pH in his urine. What does he most likely have? Well, if we see high sodium and low potassium, when you see sodium and potassium together, you should be thinking about aldosterone because that's its job. And so in this case, we would expect too much aldosterone, or choice C for that. Now, the other hormone that comes in the adrenal cortex is cortisol. And cortisol is a glucocorticoid. And this is the one mainly affected by CRH and ACTH. So CRH, we know, comes from the hypothalamus, and it goes to the anterior pituitary gland where it triggers the release of ACTH. ACTH goes to the adrenal gland, the adrenal cortex, and it primarily triggers the release of cortisol. Some aldosterone, mainly cortisol. So there's two things to think about here. Number one, we know that CRH is highest first thing in the morning. So bursts of cortisol also occur first thing in the morning. In fact, this is why you wake up. If you wake up naturally without an alarm clock, your cortisol levels are going to peak in the morning, and that's what's supposed to wake you up for your circadian rhythm. However, we also know stress directly affects CRH. Remember the hypothalamus, right? The mind-body connection. Stress is linked into our hypothalamus, which causes an increase in CRH. So when we're stressed, we release more cortisol. So cortisol's nickname is the stress hormone. So if you're stressed, you're going to have a hard time sleeping, right? Because when the levels go up, you wake up. Well, if your levels are elevated at 2 a.m., you're not going to sleep very well. So that's one of the reasons why stress interferes with sleep. Now, this is a glucocorticoid, so it affects your blood glucose level. When you release cortisol, your blood glucose goes up. And again, it's going up because your body's under stress and it thinks that it's going to fight or flee, but you need the glucose, right, to get to your muscles. So that's one of its main actions as we look at this. So if we look at our stimulus again, we have early morning is going to trigger the release, stress, and our fight or flight, right? Sympathetic nervous system, which is basically stress. So we know all of these things affect the hypothalamus and CRH. And so CRH is going to release more of that ACTH, and then that will release cortisol. So its job is to try to raise your blood glucose levels. So it does it through several ways. Well, one thing is it does gluconeogenesis, and mainly the liver does this. So what that means is you take amino acids and glycerol and you make glucose out of it. You're making new glucose, right? Genesis, formation of. So its job is to maintain your glucose level. It's going to break down amino acids from your muscle tissue. Well, you don't really always want this to happen, but you'll be breaking them down because you're trying to make glucose out of them. Also going to break down fat, right? You're going to mobilize or break down fatty acids so you can burn them for energy, but also so you can convert them into glucose. And it affects inflammation or your inflammatory response. So it tends to suppress inflammation. And it's a critical hormone. We need it to get through, it could be when you're sick, your cortisol levels go up. So you have enough of, your glucose levels, you have energy for your immune cells to fight the infection. The problem is when we have it elevated too long. And this is usually from chronic stress or cortisol. You might have heard of prednisone, which is basically cortisol because it's anti-inflammatory. And so sometimes if you have a condition like an autoimmune condition, you might take prednisone daily. So you could also have excessive levels, not just from stress, but if you're on medication that raises like a prednisone, some sort of immune suppression medication. So if it's elevated chronically, it tends to interfere with bone formation, right? Decreases bone formation, suppresses inflammation, which again, if you have like a cortisone cream, right? Cortisol, those creams, it's good to suppress like red, itchy rashes, but you don't want this systemically and for too long. It actually suppresses phagocytosis in your immune system. High levels decrease white blood cells. They're called eosinophils. Your thymus gland, we're coming up with that in a future lecture, but your thymus gland makes hormones. It's above your heart, and it trains your T lymphocytes. You've probably heard of your T cells, affects antibodies. And for some reason, it changes your body fat. It causes fat to form on the back of the neck, the belly. You get a lot of belly fat, and around the face. So what you're seeing here is something called Cushing's disease, which is too much cortisol. And you can see the individual before and after diagnosis, and your textbook has a picture. So if you have Cushing's and elevated cortisol, you're going to have hyperglycemia. So your blood glucose levels are going to be elevated too much. Your muscle protein, right, it gets broken down. So your muscles are going to lose their muscle strength and their muscle tone. You tend to have hypertension and get a lot of edema, and the redistribution of fat. So there tends to be some fat on the back of the neck, and then also the face changes and gets more like a moon or rounded facial features to that. Now, Addison's disease is hyposecretion of both cortisol and aldosterone, so both of them. So individuals here tend to lose weight. They have low glucose levels because they don't have cortisol, and they have low sodium levels because they don't have enough aldosterone. The potassium levels go up in their blood because remember, aldosterone kicks potassium out. So now they're holding on to potassium. They're losing a lot of sodium and water in their urine. So they're urinating a lot. They're dehydrated. They have to drink fluids a lot, and their blood pressure is usually too low because of that. Now, the zona reticularis, remember this zone is the deepest zone, and it makes things called androgens. So an androgen is basically a precursor to testosterone, and you may have heard of one called DHEA. There's several, so we just say adrenal androgens is what's made, and these tend to have a greater effect in women than in men. So these are precursors to estrogen and testosterone. Males get a little bit of estrogen from their adrenal cortex, and females get some testosterone, these androgens, from their adrenal cortex. However, most sex hormones are made in the gonads. Okay, this isn't taking the place of them. You just get a little bit here. It is under control, a little bit of CRH and ACTH. But what mainly is going to happen here is in women. So if there's a problem where you have too many androgens produced, then it's going to masculinize the female. So the female might be more muscular. She might have like excessive body hair, excessive facial hair, and that's what would happen. Primarily, there's an issue here. Okay, adrenal medulla. Already been there, done that. You see that's the number 1 here. You can see the inside of the adrenal gland. So these are special cells. This is part of our sympathetic nervous system. It makes the norepi and epi, which are called catecholamines. So remember, when we did the sympathetic nervous system, we talked about that preganglionic axon, right? Can come all the way down into the adrenal gland. Trying to write some of that here. So if you remember, your sympathetic, right, had 3 different places it could go. It could go to that chain ganglia on the side, the collateral ganglia in the front, or right to the adrenal medulla. And when it goes to the adrenal medulla, the hormones norepi and epi are released, and they're critical for our response, basically our fight or flight, or our stress response. So generally speaking, these are more involved in our short-term stress response. So again, you can see the image here. You see your spinal cord coming out. You can see your preganglionic coming out. And then, you know, our quick things that we've talked about already, our heart rate goes up, our blood pressure goes up, our blood glucose level goes up, right? It opens up our bronchioles, so our respiratory rate goes up. Our reticular activating system, right? Remember our RAS from the brain kicks into high gear. We're more awake, we're more alert. And these are all our short-term stressors that are primarily due to epinephrine and norepinephrine. Now, the long-term ones are more like the, you know, that goes more than minutes. These are things that last hours to days. And this is where we get the other hormones, the adrenal cortex involved. So this is where we're looking at our effects of cortisol and to some of, you know, a little bit of aldosterone. So this is where we're going to have increased blood glucose levels. So if you're diabetic, you have diabetes mellitus, you're trying to control your blood glucose and you're stressed a lot, it's really hard because the stress is raising your blood glucose level. Your immune system gets suppressed, right? Long-term stress, it's not healthy for us. We have higher blood pressure, higher blood glucose. So it's really important that you find some things to help you deal with stress. Exercise is awesome, meditation, prayer, music, right? So try to find a way to deal with stress, breathing, taking deep breaths. It really does help activate your parasympathetic nervous system as well to help you deal with the stress. And so it's important that you're able to do that. So I put this in the PowerPoint. It's from your book. It's just a little table that kind of goes over the hormones from the adrenal cortex. Again, what you're learning is for every hormone, where does it come from? What stimulates its release? What inhibits it? What does it do, right? What's its target and what does it do? And I think it's really good to make up index cards and on the front, put the name of the hormone, and on the back, you can write triggers for release, inhibitors of release, effects, right? And then the gland it's released from. And I have a bunch of those made up for you in Blackboard, but I think it might be good for you to go ahead and do that, and it'll help you learn these hormones. So this concludes our lecture on the adrenal gland.